Over to you, Saptarshi.
Thank
Please.
you, Anibandha, for the kind words. So, though I have been in Delhi for almost last 20 years, so I am originally from Calcutta. I did my MBBS from Calcutta Medical College only. So, I think so. This is just a continuation of where the last two talks were. So, we talked about the different types of diabetes, then Deep talked about childhood obesity, and we will be looking into what we need to do as an endocrinologist for pre-conceptional checkup. So it's many. So when I got this topic, it's difficult to summarize because first of all, you need to. So there are so many endocrine disorders which have relevance, starting from thyroid, diabetes, PCOS, hyperprolactinemia, pituitary. They directly affect the fertility and the pregnancy potential, and there will be others like pre-diabetes, obesity, overweight, vitamin D deficiency, dyslipidemia, which might indirectly affect them. And in all these cases, you actually need the counseling from an endocrinologist. So if somebody has an overt disease, the endocrinologist obviously has to treat it. But even if somebody is not having an overt disease, with Deep said that he just talked on childhood obesity, and all these children, girls, when they grow up, they will carry this obesity with them. So we have a huge number of women who are planning to conceive have obesity and have multiple problems related to it. So even in some cases, though primarily the fertility issue will lie with the gynecologist, but sometimes endocrinologists do have a role to play. And we need to be sure that we are preventing any pregnancy complications. So it has the role of an endocrinologist, it has short-term impact in terms of maternal health, but also long-term impact in terms of fetal health. And just to make it simple, I will keep it as a case discussion. So, and if the audience can pitch in if they want to have an opinion. So it's a 33-year-old lady, known case of hypothyroidism. She is planning to conceive, currently on levothyroxine 62.5 mcg. T3, T4 is normal, TSH is 2.12. So do we need to do anything? Same dose, increased dose, decreased dose? So we continue with the same dose. But what additional information we need to give in all these cases, all these women, is that the target TSH is 2.5. That is okay. But whenever they conceive, in the initial part, the maternal thyroid is responsible for maintaining fetal health and fetal growth. So the dose of thyroxine levothyroxine has to be increased by 20 to 30% immediately on conceiving. So that is a very, very important aspect. And this, many of these women are having hypothyroidism. We need to ensure that. So if you, whenever somebody is coming with you already taking medications for hypothyroidism, you need to discuss whether there is a planning for conceiving or not. And if it's there, we need to increase the dose. We can just tell them till you meet the doctor, increase, maybe take additional 2 tablets on Saturday, Sunday. So if they're valid, just to make it simple, so if somebody was taking 62.5, maybe Saturday till the doctor is available, or even meeting the doctor, take 2 additional tablets on Saturday and Sunday. So we now move on to a slightly more complicated cases. That was like a basic case. So 34-year lady, 3 first trimester abortions in the past, all reports normal except TPO antibody, which is 894, clearly elevated. So do we do anything in this case? So again, any opinion? Do we replace thyroxine? We do not replace thyroxine. So there is a link of, there is a clear-cut association that in case of a elevated TPO antibody, even the person, even if the woman is euthyroid, there is an association with recurrent spontaneous abortion. But the question is, if you are giving thyroxine, are you able to prevent that? So this was a Lancet Diabetes and Endocrinology paper published in 2022. So they recommend that this was just a RCT which was done, which is like the only RCT that has been published. Otherwise, it's mostly case reports. So their finding was that even if you are supplementing thyroxine in these cases, it does not improve the pregnancy rate. The numbers were not that many. They only had around 80 patients. They were planning to get 120 patients. They could not reach the numbers because of low recruitment. So it's a gray area. But as of now, if you look into the ATA guidelines also, there is no indication to supplement thyroxine. And in this particular case, it might be proved wrong if we have subsequent studies, but current evidence is that there is, as of now, no role. So this is slightly even, this will come into the domain of endocrinology, because whenever hypothyroidism is easy, is not every time we will require an endocrinologist, but hyperthyroidism specifically in the setting of pregnancy. So there has been some changes, and we need to understand those changes. So clearly, was diagnosed with Graves' disease around 1 year back. So this was the baseline thyroid function test where the total T4 was clearly elevated, TSH clearly suppressed, was started on a dose of carbimazole 30 mg per day, and monitoring of thyroid function test was done by measuring T4 is important in this case, and all TSH normalization might take time, and it was after monitoring, when it was we try to do is try to gradually decrease the dose of anti-thyroid medications. So, but when the dose was when a dose reduction below 20 mg was tried, she again became thyrotoxic. So now on 20 mg, her total T4 is 10.9, TSH is 0.42, almost control. So if the lady wants to conceive, so do you now continue carbimazole? Do you shift to propyl thyroxine? Do you consider radioiodine, or do you consider surgery? Again, any opinion? So that is again an evolving area. So in this case, you have actually 4 options. So you can, this is ATA hyperthyroidism guideline 2016. So definitive therapy, usually surgery is not done, but if somebody is offered a radioiodine therapy, there is a transient increase in TSH receptor antibody that passes on to the fetus, and besides, radioactivity will have its own negative effect. So conceiving should not be planned for 6 months to 1 year, and the lady will most probably require thyroxine for rest of her life if you do an ablative procedure. So that is one option. People do go for it. But you really need to be careful. Preferably document a TSH receptor antibody that it has gone down, not TPO antibody. TSH receptor antibody is different. It has functional significance. So you can get that antibody test done, and then plan, and the lady can plan pregnancy. Another option is to switch to PTU before conceiving, or another option is you can switch to PTU just after conceiving. And another, if the dose requirement is really low, so the medication requirement can actually go down in pregnancy. So in that case, you can even give a trial of stopping. So these are the advantages and disadvantages. So maybe 10-15 years back, it was a standard teaching that you shift to PTU during pregnancy and lactation in all cases. But what has been seen is that PTU has a lot of fatal hepatic necrosis possibility. 1 in 10,000 is there. And so even requiring liver transplantation or causing mortality. So most of the guidelines have really been guarded regarding long-term usage of PTU. So the idea is that it's an idiosyncratic reaction. It's not predictable. So idea is that you give PTU for as short duration as possible. Do not give propyl thyroxine for very long duration. So in somebody, if a younger female planning to conceive, regular periods, no issues, you can shift to PTU, and then after maybe once after say 12 or 14 weeks, you can shift back to methimazole or carmazole. If you are anticipating that the lady might take a longer duration, older age, PCOS, irregular periods, you can continue with methimazole or carmazole, but you have to give very specific instruction. Whenever pregnancy is detected, she has to be shifted to propyl thyroxine. So all this is because the chance of teratogenicity with propyl thyroxine is lesser than that with methimazole. So aplasia cutis, guanal atresia, esophageal atresia, omphalocele, all have been reported. The propyl thyroxine itself also causes around 2.3% of anomalies, but these are milder anomalies. So I will show you some of the examples. So this is aplasia cutis.